Tonight we are talking about diabetes mellitus. One of the main concepts I'm going to go over is glucose regulation. Obviously, nutrition, tissue integrity, sensory perception, immunity, fluid and electrolyte, and acid-base balance are huge concepts when we're talking about care of the diabetic patient. So we will be touching on those as well, but I really want you to focus on glucose regulation as I'm going over the various concepts. So what is insulin? Insulin is made by our pancreas, and this is how we metabolize sugar, right? How we metabolize glucose. So if you don't have insulin, you cannot metabolize glucose and you're going to become hyperglycemic. So pancreas makes insulin. Type 1 diabetics do not have a pancreas that works. So think of insulin as the key that unlocks glucose so it can be driven into cells and metabolized. Okay? Someone who's a type 1 diabetic, and I'll get into more detail about that later, is missing that key. They are not able to make insulin. Someone who's a type 2 diabetic, they make insulin have the key, but the key is a little bent, doesn't fit in the lock just right. So those patients are not going to necessarily be treated with insulin, but be treated with a medication that adjusts the key so it will fit and they can metabolize the glucose. A type 1 diabetic is always going to need insulin. They don't make it. Their pancreas doesn't work. So if you don't make insulin, what happens? Think about the 3 Ps: polyuria, polydipsia, polyphagia. This is how many type 1 diabetics are often diagnosed. They have an increased urine output. They are so thirsty. Because they're so thirsty, they pee all the time and they're hungry all the time. Their body is breaking down um, muscle. They have ketones because of that in their urine. They're not able to metabolize glucose. Therefore, their body is having to metabolize protein. Because of all of this sugar, it's making their fluid and electrolyte balance off, so they're hemoconcentrated. They don't have a ton of fluid in their intravascular system because they are peeing all the time. So they're actually hypovolemic. They're going to have low blood blood pressure. Sorry. And hyperviscosity. What does that mean? It's like the blood is thicker and more viscous. What would happen if you have hypovolemia? Because of hypovolemia, low blood volume, you're going to have hypoperfusion. If you have hypoperfusion, you're going to have hypoxia because the red blood cells are what carry oxygen to cells. So think of all the problems that can happen in your microvascular and macrovascular system if you have hypovolemia, hyperviscosity, hypoperfusion, and hypoxia. This is why you're going to see problems with eyes and kidneys. That's your microvascular system. You're going to see it's not going to get all the way down to the tips of your toes and your fingers. So you're going to see decreased perfusion in lower extremities, which leads to diabetic ulcers or decreased wound healing. If someone is very hyperglycemic, so in the absence of insulin, you're going to become hyperglycemic. Someone who's very hyperglycemic is actually going to become acidotic. And one of the signs of the metabolic acidosis, which is called DKA or diabetic ketoacidosis, which we'll discuss later, are Kussmaul respirations. And this is that air hunger. It's rapid gasping, deep breathing. So again, these are different symptoms of diabetes. The blue are going to be more common in that type 1 or insulin dependent. And I'll let you go through and look at that. So again, I talked all about this. You have macrovascular and microvascular disease because of all those issues. So you're going to have vision problems, kidney dysfunction, nerves dysfunction. These are all types of things that can happen. You're going to have macrovascular complications, cardiovascular disease, cerebrovascular disease. Think, you have this viscous blood, so you're at risk for clots, which is going to lead you to stroke, right? Also, your microvascular system. So this is what goes to your eyes, your nerve systems, all the way down to your kidneys. So that's where you're going to have this nephropathy in your kidneys, right? Nephrons, kidneys. Neuropathy is going to be your nerves. They're going to have decreased sensation in their tips of their fingers or their feet. They're at risk for stepping on a nail and not knowing that it's cut their foot, right? That's how a lot of diabetics will actually end up with wounds in their feet, is they don't feel it. They may get burned because they touch something hot and don't recognize that it's hot. If you have decreased blood volume and your blood volume is not able to fill that microvascular system, you're going to have problems with sexual dysfunction in males because you need to be able to get blood flow for to maintain an erection, so they can have erectile dysfunction. And never underestimate how much sexual dysfunction can really psychologically affect patients. Sometimes that's one of the things they're most concerned about. So we always have to really think about all of these different parts of their body that are going to be affected, and also how it's psychologically going to affect them. Not being able to see, right? They can have cognitive dysfunction. Again, here's a picture of diabetic ulcers. Um, this is a picture of, I'm not going to say it right, eruptive xanthomata, which can be caused from high blood sugar. So I'm going to let you go ahead and just look at the different things on that picture. One thing to keep in mind is that a pregnant mom who develops gestational diabetes, or is actually already a diabetic when she gets pregnant, is going to have this high circulating blood glucose. And we know that when children are exposed to this in utero, they're at greater risk later in life for type 2 diabetes. So, something to keep in mind when you're taking a health history of a patient. Type 2 diabetes. So, remember, these are the patients that they have a key, they make insulin, but the key's just a little bit bent to get into that glucose and make it drive into cells to be metabolized. So, again, you're going to see the same kind of damages with these patients as well. Metabolic syndrome is something that we are seeing more and more often as it's patients who actually have multiple health issues kind of happening concurrently. And so these are patients that have high blood sugar, high blood pressure, low, that good cholesterol, high triglycerides, and they often have that apple shape, excess fat around their waist. So if a patient presents like this, one of the first things you're also going to want to do for them, so they have high blood pressure, they're overweight, they have high triglycerides, is you're going to check their blood sugar, because we know that they're at risk for this metabolic syndrome, and all of those diseases are kind of happening concurrently. So again, type 1, your pancreas does not make it, you don't have a key. Type 2, you have the key, but it doesn't work real well. And then just an example of metabolic syndrome, a definition of it. So I'll let you read that a little bit more. Again, this is just a picture that's going to show you. Remember, type 1 diabetic patients are going to need insulin for the rest of their life. These are the patients that are monitoring their blood sugars throughout the day. They may have an insulin pump. This is an absolute life-changing disease to be diagnosed with. When it's a child, it's going to affect their schooling. They're going to need to be able to have school nurses and people that are trained in how to notify and recognize who to notify and how to recognize if they're hypoglycemic or hyperglycemic. Their parents are going to need a lot of education. There's dogs even that are trained to sleep in children's rooms and recognize if they become hypoglycemic. I think that's really interesting. So type 1 diabetic patients are really going to need a lot of education. And this education is going to need to be staged based on their age and what they're able to understand. And a lot of the education may actually need to occur to the parents and their caregivers. So really between ages 10 and 15 is when most people are diagnosed with type 1. And it's an absolute life-altering diagnosis to be given. So I just want you to keep that in mind when we talk about patient education. It can be very difficult when people become teens and young adults and they don't like having a chronic illness and they want to be able to control it themselves, and they may not be as compliant because they don't want to look different from their peers. And that can be really tricky. And it can really be something where patient education is really key in helping these types of patients. Here's an example of someone with type 2 diabetes. It's kind of a sad looking picture. She's eating more and more chocolate. But this is someone, your fasting blood sugar is greater than 126. They may not present with as high blood sugars because remember, they have a key, it's just a little bit bent. But we're seeing these in people over 50. They're obese. They're having lots of infections because infections love sugar, and those infections are just eating that circulating glucose. Often, if these people can have lifestyle changes, lose weight, change their diet, many times type 2 diabetes can be diet controlled without a medication. So again, we've talked all about how diabetes affects the micro and macrovascular system. So one of the complications that occur with diabetes is called diabetic ketoacidosis. Okay, and this is basically severe hyperglycemia. And there's two types. There's diabetic ketoacidosis, and there's HHS. HHS stands for hyperosmolar hyperglycemic syndrome. Um, and basically, in these patients, they have had higher blood sugars for a long period of time. So they have severe dehydration and thirst and confusion. So DKA, you typically see in people under 45. They do not make insulin at all. So they're type 1 diabetics. And it's more of an acute episode that happens. So maybe you have this college student, he goes out, he forgets to check his blood sugar. He's drinking alcohol, which we know affects your insulin production, or he doesn't produce insulin, but we know affects your blood sugar production. Um, doesn't take the insulin, ends up partying all night, goes out for a burrito after partying, goes to bed, and wakes up with nausea, vomiting, pain, that um, thirst, that hunger, air hunger, sorry, very thirsty. You can actually smell the sugar in their breath. Think about that. Always think if you can smell sugar in their breath, that's because you have all this high circulating sugars. And you're hypotensive, right? Your blood volume is going down because it's so acutely concentrated with sugar. That's DKA. HHS is something you're going to see more in a type 2 diabetic who's over 60. So this is a patient that does make some insulin, but for whatever reason, maybe they're 60, 70, 80, they're on Medicare, so they're over 65. They've run out of money for their prescription for metformin that they're on to help get that key to fit to metabolize sugar. So they've stopped taking their metformin. And maybe they have an infection and are sick, so that's affecting their blood sugar and their body can't metabolize the sugar. This patient's maybe in a nursing home and has some sort of underlying infection going on. So these patients are severely dehydrated. Um, they have had, they have been peeing a ton. They are, very hypotensive as they get more and more dehydrated as well. And so, you often will see HHS in a nursing home. That is why it is so important to make sure that they're monitoring output in these diabetic patients. So the big differences between DKA and HHS is one is more in a type 1, one is more in a type 2. DKA you're going to see more in type 1, younger than 45, HHS greater than 60, more of a type 2 diabetic. DKA is more of an acute episode that happens. HHS has kind of built up through the years. Not through the years, through the days. It's kind of happened over a few days more of versus an acute episode. How do we treat DKA? We need to look at potassium because our electrolytes are going to be off. Insulin, they may get an NG tube. You always are going to give glucose when you give insulin. It's a balance of both. I know that seems weird, but we do that. We're going to be monitoring the urea and creatinine and make sure those kidneys haven't been so affected, okay? We do not this kind of patient is at increased risk for going into kidney failure. When you are urinating so much and you are so dehydrated, you're at risk for kidney failure. HHS, one of the biggest things they need is to get these patients hydrated and to treat the underlying cause. DKA, the underlying cause is they didn't have insulin. HHS, what is the underlying cause? Did they have infection? Have they run out of their medication? Have they keep forgetting to take it? What's happening? Okay, so those are kind of two big differences to think about. What does insulin do for a diabetic patient who's in DKA? It drives that glucose into the cells. We need to get glucose out of that circulating vascular system and into the cells. Okay, it drives potassium into the cells. It helps to combat the catabolism that is breaking down muscle tissue and causing ketones to be released. So again, blocks that protein breakdown. Things you also want to talk about whenever you're assessing a patient, or things you want to think about are, what are the blood tests we use to test for diabetes? You want to take a patient health history. This is how you're going to identify possible metabolic syndrome. Or what if the patient says, I've just been peeing so much, I've been so thirsty. The more I drink, the more I pee, the more I drink, the more I pee. I just cannot quench my thirst. Ding, 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 ding. I've been losing weight. I eat and eat and eat. I'm hungry all the time and I'm losing weight. Ding, 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 ding. This can be, if a teen presents with those are all three big red flags for type 1 diabetes. You're going to do a fasting blood sugar. What's going on? One thing that's not on here is, it's that glycosylated hemoglobin assays. That's actually hemoglobin A1C. That's going to give you a 3-month snapshot of what their blood sugar has been. So that's a very good indication, A, to test if they've been in good glucose control. Did they just take their insulin because they were coming to the doctor, or have they been doing well? I always think to these college students, a hemoglobin A1C is going to really give a good picture of how they've been managing their blood sugar, on their own. We know in pregnant patients, we do the oral glucose tolerance test while they're pregnant. We actually give them a boost of sugar and see if their body can handle it. So those are different things that we look at. Someone who's been a chronic diabetic, whether it's type 1 or type 2, one thing that's going to happen is they're going to look and see, has there been any of that neuropathy? Has there been nerve damages to that microvascular micronerve system in their feet? Because these patients, if they have decreased sensation in their feet, it can affect their balance. It can affect the integrity of their skin. We've talked about if they can't feel things. So again, look at all these different things that we can come up with, and I'll let you read through all of these, okay? So whether it's HHS, DKA, hypoglycemia, all different things that these patients are at risk for. We use insulin and different kinds of medication, diet for some type 2s. Some transplants are done in chronic type 1 diabetes. That's really interesting. I don't know a lot about pancreatic transplants, but it'd be something that would be interesting to learn about. And again, all of these different things that we're looking at. How can we protect their vision? How can we protect their kidneys? It is so important that patients are in good glucose control to reduce their chance of having these complications. Circulating sugar is like burn. I always think of all that circulating sugar as it like burns everything. It's just damaging to all of those vessels and nerves. And again, infections just eat it up and eat it up and eat it up. And so it's so important that a patient has good control. The number one determining factor of how a patient is going to react to treatment to diabetes, how they're diabetic, how their diabetes is going to be controlled is patient education. And these are all different topics that we're actually going to do in class tomorrow. We're going to look at actually many of these different topics in a patient education group activity that we're going to do. But patient education is probably one of, if not the most important determining factor in someone developing complications for diabetes. And I want you to think about all of the different things that play into education. How old are they? Is this a child? Do we have to involve the parents? Do we have to involve the school? Is this a young adult who isn't receptive? Is this a teen who isn't receptive? Is this someone older who has dementia? Can this person, afford their insulin? Can they afford, are they homeless and they can't afford insulin? What do we do? Lots of different variables that can play into this. So we're going to talk about that more in class today. And again, these are different things that we'll be going over when you do an actual case study in clinical. This PowerPoint presentation actually includes a case study and then some practice questions, and the answers are in the boxes underneath. So I will post this whole PowerPoint presentation to Blackboard, and then you'll be able to, if you want a little practice, do the case study that's in the PowerPoint and answer the questions. That's it for tonight. I hope you all have a good night.